Mr. JD is a 48-year-old man with a history of hypertension who presents to the emergency department with chest pain as of 12 hours duration. JD was in his normal state of health with well-controlled blood pressure with medications until 12 hours prior to his admission. He was diagnosed with hypertension in 2019 when he presented to the emergency at that time with headaches, blurred vision, and excessive sweating. His hypertension and symptoms have been well controlled with his medication use. Typically, his blood pressure sits at 124/80 with his medication. He has had no recent episodes of hypertension, headaches, blurred vision, or excessive sweating. He has been inconsistent with his medication as of the last 6 weeks, and he's also gained 15 kilograms in the last 6 months. His chest pain began last night at 2100 hours while heading upstairs in his home. His pain began at a 3 out of 10 and progressed to a 7 out of 10. He reports the pain as a squeezing and sharp pain in his medial, anterior, and posterior chest. Walking up the stairs causes a 7 out of 10, while resting decreases the pain to a 2 out of 10. JD has arrhythmia last night, and he also reports feeling anxious right now. He chewed 325 milligrams of aspirin at 08:15 hours this morning. His father has a history of hypertension and had an MI at age 52, and his brother also has a history of hypertension. In terms of his pertinent positives, he does have a history of hypertension, a family history of hypertension. His father had an MI at age 52. Currently, he's having chest pain upon exertion, arrhythmia, experiencing fatigue, recent weight gain, peripheral edema, and anxiety. In terms of pertinent negatives, he does not have any chills, headache, slurred speech, neck pain, arm pain, jaw pain, or recent trauma. He does not have a history of diabetes, high cholesterol, history of DVT, PE, or a bleeding or clotting disorder. He has not had any recent travels or sitting for long periods of time, hemoptysis, melena stools, urinary symptoms, emesis, local weakness, paresthesias, or decreased gait stabilities. For his medication history, he has been taking valsartan 80 milligrams twice a day since 2019. And also, as mentioned, he chewed 325 milligrams of aspirin prior to his emergency department visit at 08:15 this morning. He does not have any allergies he's aware of. He does have a history of hypertension when he presented with blurred vision, excessive sweating, and headaches, as mentioned. Other than that, he is medically stable. JD is married to his wife and has 2 children, aged 10 and 14. He reports that he does not drink any alcohol, smoke, or use recreational drugs. He has a history of anxiety since he lost his job as a lawyer 6 months ago. He says he did not seek any medical help or medications for his anxiety, and he's been managing it okay at home without any concerns. His vitals include the following: blood pressure 80/54, 112 beats per minute. His temperature is 36.5 degrees Celsius. Respiratory rate is 25 beats per minute. Height is 176 centimeters, and weight is 84 kilograms. We also took some serum samples and cardiac enzymes. The following showed abnormal: BNP 145, which is high. LD is 2,160 international units, which is high. Hemoglobin is 123 grams per liter, which is low. Sodium is 121, which is low. And creatinine is 1.6 milligrams per deciliter, which is also low. We also had the opportunity to obtain a 12-lead ECG and have noted that he has a prolonged QT interval, and ST and T wave abnormalities are present. I also had the opportunity to do a peripheral examination on him, and I noticed that his palms and his soles of feet were both cool and clammy. His pulses were okay, besides his dorsalis pedis pulse, which measured at grade 1. He does have a grade 1 mild pitting edema to his feet and a 2 millimeter depression that disappears within 1 second, but he doesn't have any pitting edema to his ankles or his legs. However, his cap refill of his toes are 7 seconds. I did do a cardiac examination as well, and I heard a bruit over the left carotid artery. His JVP is measuring at 5 centimeters above the sternal angle with the head of bed at 45 degrees. He does have Hebs that are palpable upon systole. I did measure an apical impulse, and I palpated at vertically at the fourth intercostal space, and midclavicular line. The amplitude of this pulse was brisk and non-sustained, and the point of maximal impulse is diffuse and measured at 2 centimeters in a supination position. There is a right-sided S3 present during inspiration, and I was able to hear a hollow systolic soft, grade 3 out of 6 decrescendo murmur, and this was identified at the base and the left sternal border. In terms of his respiratory exam, he is presenting with tachypnea and increased work of breathing. His chest tissue expansion is measuring at a 2 centimeter depth. He does have tactile fremitus pronounced at the clavicle and decreases towards the base of the lungs. I did palpate his diaphragmatic excursion at 4 centimeters. I was also able to hear some loud and harsh expiratory bronchial breath sounds in the lower bilateral lobes of the lungs. I did also hear some brief and loud coarse crackles in the posterior inferior lung, but he is negative for egophony. So in summary, we have a 48-year-old man with a history of hypertension presenting with acute chest pain. He has increased creatinine kinase, increased BNP, low hemoglobin, and hyponatremia. He also presents with peripheral edema, S3 on auscultation, and increased JVP. His ECG is remarkable with prolonged QT interval and ST and T abnormalities. We should begin examining JD for the diagnosis of congestive heart failure. He may also have a differential diagnosis of acute renal failure, acute respiratory distress syndrome, anxiety disorders, and anemia. Thank you.